So, good afternoon. Welcome to another session of IJCCM Best Article of the Month. This time we have a very interesting study on salt-based or balanced solution trends in Indian intensive care units, a multi-center prospective observational cohort. So, first I'll ask Dr. Sachin to tell us about the main findings that you found in this. What were the fluids that were used, and what were the main findings?
Yeah. Thank you, Dr. Banani, and thank you, Dr. Kulkarni. So we realized that there is no hardcore data about what are the fluid practices in this country. They were small sporadic studies. So we initiated this study pre-COVID, and that's the reason we actually had earlier framed it for almost a year only, but then we had to extend it for 3 years because during COVID, the data collection was not possible. So we looked at the fluid practices for first 3 days of the ICU admission of a patient. All categories of patient, both medical, surgical, post-operative, but they had to stay in the ICU for 3 days. So we wanted to understand, are we still using more of saline, or are we inclining towards balanced salt solution? And is there actually any difference if you're using these two categories of fluids? We labeled them in different manners. So we said, if you're resuscitating a fluid beyond a certain level, then this becomes a resuscitation fluid. You have to calculate that volume and put it. We also said maintenance fluid, what you give as 50 ml, 60 ml per hour as a maintenance fluid. What is that fluid that you're giving? And let's say you're just replacing for some losses. Patients have a GI loss, you are replacing 200 ml, or patient has a vomitus, you are replacing that volume. If you are doing that, please look at that volume and what fluid you are giving. We just wanted to look at crystalloids, so we removed all colloids and albumins and all these from the calculation part. Yes, because we did not ask anybody to change their practice. We said, whatever you are doing, please capture that, and then we try to analyze this data. So end of the day, we divided the data as normal saline group, balanced salt solution group, and ringer lactate solution. We did not put ringer lactate into balanced salt solution. We were looking at newer balanced salt solution versus the older ones. So this is what the data was.
And your main findings?
So they are absolutely contrary to what the literature says. See, if you look at the bigger trials, the international trials, they all said whether you use balanced salt solution or saline, it did not make any difference in AKI or ICU mortality and other stuff. What we realized is that in our Indian subset and whatever the practices were and the data which was shared, balanced salt solution had an edge over the other two solutions, right? In terms of reduction in the ICU length of stay, reduction in the mortality, reduction in the AKI, but it did not show any reduction in the incidence of RRT, which was surprising. So patients who were undergoing RRT were more or less statistically non-significant between the three groups. But balanced salt solution was the best among all the three groups. Then we had ringer lactate and then the normal saline. So the culprit looked to be the normal saline there. I would interpret this data as, because we were doing a very specified time frame for the data collection. We were looking only of the first 3 days, very early during the course of the disease status when the patients has other issues also. Whereas most of these trials, international trials, have looked at 7 days to 12 days of fluid resuscitation and fluid management. So probably by that time the incidence of AKI may have settled down, right? And that's the reason you don't see that difference in other trials. And what we see, that balanced salt solution has a little edge over the other two solutions. I feel because of a short duration of the data collection, that's the reason I feel the results are coming to be different from the other contemporary trials.
So, Dr. Atul, you want to say something?
I think it's very difficult to explain the difference in our findings in the solute study as compared to other, just going by the period of data collection. The reason being that if you say that your data collection is only for 3 days and the other studies are 7 or 12 days, my problem with that is that if you, so normal saline harms by harms the patients or the kidneys when you present a big load at the same time. Meaning
Agreed,
you
sir.
have to have been giving large boluses, which is most likely to happen in the first 3 days. So I completely understand the logic of the authors when they designed the study, because that is the period where you are going to give maximum amount of fluid. By 3 to 7 days, if the patient is unstable, okay, I mean still unstable after 3 days of being in the ICU, it's unlikely that he's going to do well anyway. If he's still continuing to
Right.
receive, by then you are in the optimization phase or even deresuscitation phase. So the effect of fluids is likely to be highest within the first 3 days, and that is going to actually affect the outcome. Now, I am not really sure why we got the results the way we got, because the ringer lactate solution is not really that bad in terms of chloride load. When you compare it with normal saline, of course, it is much better, but it's not too bad even when you compare it with the balanced salt solution. Considering that, we shouldn't be getting the effect uh, particularly in the AKI, but like we said, we considered only first 3 days. Some patients might have had AKI before instead of developing it. So we actually, if we have the complete data, I would be very, very interested in looking at how much was the proportion of fluid and what fluid was given before admission to the ICU, what happened from 3 to 7 days, what was the positive fluid balance of the patients.
Put that data also in the study as well about the daily balance, fluid balance, and the type of fluid. And we realized that the majority, so saline group actually was given a higher fluid. So, as you rightly said, first 3 days when you are actually pushing the fluid into the patient, this hyperchloremic metabolic acidosis, which was more because of the saline load, was the primary reason. What we understood was responsible for certain extent of AKI in these patients. As far as the pre-AKI before randomization was also captured, and that was not statistically significant in any of the three groups.
Okay.
So we captured that. As far as mechanical ventilation, we did not capture that data, so we will take that out. But we also looked at what is the fluid balance, daily fluid balance as per the type of fluid, and we also looked at what is the daily urine output in all the three categories: saline versus ringer lactate versus balanced salt solution. So we looked at
And
other
higher.
clinical parameters also to understand that does it really make a difference of what kind of fluid you are giving.
So, what was the volumes, approx, very average kind of
So
volumes that they were
average
getting?
volumes which were given, so I would say fluid balances I can talk about right now. So on an average, saline group on day
At higher
one had
balance.
almost a 1300 positive balance as compared to ringer lactate, which was, so on day one it was okay, similar group. Day two also they were similar. The reduction was happening 1300 to 1000 to an 800 positive balance. So there was no differences in fluid balances, understand, between the three groups. What I feel is that chloride load was the bigger culprit in pushing these patients towards AKI. Plus this metabolic acidosis, obviously the patients are not so stable enough. So in combination with their general critical illnesses, fluid also played a role in having a higher incidence of AKI. I can't take that away that somebody who is septic or who is sick, they will not develop AKI. Yes, they also contribute to AKI, but fluid does help. I would say it multiplies that. RT was there only in roughly 190 patients out of 2400 patients, only 190 patients. So that is even less than 10% patients required RRT. So yes, RRT was more or less similar, but what culminated was the ICU length of stay. So which meant that patients who did have AKI, the clinicians were still not comfortable in shifting these patients out of ICU to the normal wards. So
Yeah.
yes, the ICU length of stay was longer in the AKI group as compared, even they had not undergone an RRT, but still it was longer.
One more thing. Do you think if you remove the first 2 days, not maybe 2 days, maybe the first day data, and look at day 2, day 3, and then go to day 7 and redo the study, maybe we get something different, and that will partially remove the influence of the
Maybe. I
pre-ICU.
still feel if we are trying to capture day 7, yeah, if we are trying to capture day 7, either this incidence will narrow down, as in we may not find a difference, or if that difference is there, it would be subtle in nature. I still feel that, right? But because I don't have a day 7 data
From both of you, that based on this study, would you actually give some recommendation or some take home message? Both, maybe Dr. Atul first and then Dr. Sachin, or you just want to say that it requires more study?
No, I think, I don't think anybody in his sound mind would use only normal saline for any patient. Normal saline is actually not normal because it is not close to the pH of the blood or the plasma, and the contents are also different. So the common practice, I mean, for last 30 years, we have been using only Ringer's lactate in our ICU. We use normal saline in specific situation. If you use normal saline, of course, monitor the sodium and the chloride both. And very often it is just the hypernatremia for which normal saline is used, or for someone with severe diarrhea. So I think you should think just logically and use a balanced salt solution. If your patients can afford it, use balanced salt solution. There are many of them. We are a government hospital. We continue to use Ringer's lactate because in my mind, so far, I am not convinced that normal saline, the Ringer's lactate and the balanced salt solution are that much different.
I agree to what Sir has said, and I would also feel that uh, blindly using normal saline, I don't think so that is a practice. And when we actually, I would put it, when we looked at the data where we were getting more of salines, they were actually tier 2, tier 3 cities where we were getting it from smaller subsets, right? Smaller workplaces. So we felt that probably that's the practice of the area rather than a knowledge about the what you want to use. That just a practice. People are very comfortable in using Ringer lactate as a balanced salt solution also. So from this study, I would still say that we should just think about what fluid you want to use. Use it in moderation. Don't just start using one type of fluid. Cost is a big issue when it comes to using balanced salt solution. So still no recommendations as in what you want to change. Yes, for neuro patients, please use saline. Don't rush to balanced salt solution. That's not the recommendation. And we require a little larger time frame study to actually validate.
No, the best part of the study was the pragmatism involved in the study.
Yes.
I mean, we are actually capturing what is being done at the bedside by everyone, and which is what we want to see, and that is the way to grow.